networks. Again, here there's some shallow fluid, and then the FIPED or the shallow irregular, which is the diagnostic OCT sign corresponding to an OCTA vascular network underneath. So in pachychoroid neovasculopathy, you'll have and this, the angiography shows a lot of information, but it is diagnostic. The OCT is diagnostic. The next condition would be, in this patient, we have a lady who presented with 6/6 vision with some alterations and there's no fluid, but a slight amount of elevation over there. And on the network, you could see a small vascular network. And this is the presence of a CNVM in the absence of exudation. It's a non-exudative CNVM, a critical diagnosis nowadays. Here you see some alterations over here. And again, a diagnostic, you see an elevation there and corresponds to a vascular network, a non-exudative CNVM. And why is a non-exudative CNVM important? About 8 to 15% convert to a full-blown CNVMs in a year, so you need enhanced monitoring. So OCTA defined this condition. In the absence of exudation, OCTA defined this condition and is essential for the diagnosis. Again, another example where you see a large area of RP alterations and a peripapillary non-exudative. Now talking about MACTEL, we all know about MACTEL. You can see pigmentation, and you doubt whether this is a proliferative stage. Here you see vasculature in the avascular zone, but this is still not a CNVM. This is because of the subsidence, that is the downward shifting. Because of the downward shifting of the vessels because of atrophy, and this is still a non-proliferative with vascular invasion. It's a new concept to deal with. And here you have a lesion where you see an SRNVM, and again MACTEL. FFAs are confusing because you have the MACTEL leak and the CNVM leak also. OCTA clinches the diagnosis. A typical example: a CNVM in a MACTEL patient. So this is just to show that the avascular zone has the it has the vascular network in the OCTA. Depth resolution is one of the biggest powers of the OCTA. And here you see a leak. You don't know whether it is because of the CNVM or the original leak of the MACTEL, but on the OCTA you can see the network. Okay, this is the network. The next, we'll go to some vascular disturbances. We had a lady, a post-vaccination, and we saw this particular pattern. Here you see on the OCT is diagnostic. You see middle layer hyperreflectivity over here called PAM. Misnomer nowadays, but this is the pattern. See, you're using two of these imagings. You're using the NFAS imaging of the OCTA, which shows a ferning pattern, which is very typical of PAMM. And also you see corresponding flow void areas or the decrease in the deep capillary plexus layer between the superficial and the deep. So this diagnosis is the ferning pattern, and it is a feature of PAM. In inflammatory conditions, you see this is a multicolor imaging showing the green shows a bit of elevation, a placoidal type of lesion. You see the elevation over there, and you suspected a white dot syndrome. Here you see large areas of choriocapillary dropout, again diagnostic in OCTA posterior uveitis, and this was a choriocapillary and a diagnosis of APMPPE. Another person with metamorphopsia as the main criteria, a subtle disturbance of the RP level over here. The overlying ellipsoid zone is rarefied, and this was the picture. The OCTA shows definite choriocapillary voids. Again, the OCTA is very important to diagnosis. The underlying, it's a choriocapillary, but the underlying choriocapillaris is inflamed, and the overlying RP produces an RP epitheliitis called Clis disease. Now, this is one of the main uses nowadays, a recurrence of CNVM. How to diagnose the recurrences even before you have exudation. This is very typical. You have a couple of features, a layer going around it. This is an anastomotic channel and fine fibrillary vessels. So this is a typical example. You have a line going around it. That's the anastomotic channel, and small vessels in between these anastomotic channels. So that is a typical appearance of a recurrent CNVM. Again, the same theme goes around an anastomotic channel with recurrent branches. And here you see, if you by now 2 slides later, if you got the knowledge in us, this is a part which is regressed, and this is a part which is getting reactive. It's a beautiful picture, one single picture to show both of these things. This is a totally regressed one, but over time you see frills happening at the edges. So this is how the recurrence, you can diagnose recurrence using the OCTA, again clinching the diagnosis. This is over time the recurrent area increases. So Yeah, I'm done, sir. So again, the same thing, I'm not staying on this for more than that. Again, a beautiful picture of a recurrent CNVM at the edge. This is the edge. You see a small fibrillary and the anastomotic channel around it. Okay. So just going to this. This is also an importance in not clinching the diagnosis, but identifying the different. This is a lacy pattern. This is a medusa where the central vessel is in the center. This is a C-fan, and this is a fishnet. Why are these important? The fishnet doesn't respond well to anti-VEGF. The medusa responds the best to anti-VEGF. The last is just one more slide. Secondary CNVMs, you have a lot of what do you say, fluid. This is a myopic patient with hyperreflex. You don't know it's because of a crack or lack of crack, and the OCTA reveals membrane. So for all secondary CNVMs, the OCTA is extremely brilliant in diagnosing secondary CNVMs. Thank you so much.
Thank you, Unni. Can you tell me in the clinic, means we will have one or two questions only. In the clinic, like OCT, early fluid, early fluid appearance on OCT. Now OCTA, can you identify few lesions in CNVM which you will say I will start treatment, even if there is no fluid on OCT? On OCTA findings, will you start on injections?
At present, I wouldn't, sir. The whole postulate, the idea being that at one point of time, the CNVM it doesn't always convert to activity. So at that point, it could be a subclinical or it could be a quiescent. Quiescents are thought to be protective to the RP because it's an alternate source of neovascularization.
Yeah.
Treating aggressively at that time may lead to more atrophy than.
No, 100% agree with you about this non-exudative CNV. Beautifully, you have picked up 6 conditions here. And in 7 minutes, you have shown the 6 ideal conditions here where Octa, you cannot do without Octa, actually. The first one, PNV, it's a highly sensitive and specific. Second, you have mentioned about the non-exudative CNV. You cannot pick up with any other entities. And third, you have put MACTL2. But I have a question for you on MACTL2 because you are mentioning about, pre-proliferative versus proliferative, wherein in the absence of subretinal heme, when you have Octa, when you do, even in the pre-proliferative MACTL, you have ectatic deep plexus capillaries. And you have in proliferative, you see in the absence of subretinal hemorrhage, you see again this dilated ectatic capillaries. So how do you differentiate between the two? Do you have any additional signs to look at? We showed that presence of subretinal fluid on OCT is a marker of pre-proliferative. And so do you have any other Octa markers, or how do you differentiate between the two?
So regarding the Octa, what I would look at is that you have to look at the progression. So when you have vasculature in the avascular zone, you have to correspond it to atrophy. That is, with the atrophy, the vessels are being compressed in a very small area in the vascular zone. When you have, and then in the lower zones, the choriocapillaris zone and the lower zones, you can pick up the network. Basically, the choriocapillaris zone and the outer retinal zone, and the network is usually more fibrillary. It doesn't have the streaky, pulled up appearance. Why does the vasculature have that pulled up appearance? Because eventually the cystoids collapse and the vessels are pulled towards specific points. It's streaky away from the center. But the CNVM, in my view, does not follow these rules. They move in multiple directions. They have vasculature which is curvilinear to the center of the fovea, not only streaking out from the center of the fovea like a subsidence invasion would look like.
So just to extend sir's question, like for quiescent CNVs, we understand that we may observe, but what about the recurrences that you see?
The number of questions to as minimum as possible so that we can adjust all the time. Can we proceed? Dr. Naveen Sakuja, can you come on to the dais and use, because we given him the next chance, we will speak later on.
before he is starting.
So my question was,
Yeah, in between you can ask. By
My
the
question-
time he gets ready, you can ask the question to him.
so like we know in quiescent CNVs we will not be intervening, but what about recurrences? When we have recurrences just seen on Octa and not on, there's no fluid on OCT. So when you have these vessels that you're seeing on the Octa, there is a recurrence. So are you still going to wait at that time, or would you inject at that time?
No. See, the very point of recurrence is being, and the very point of OCT in recurrence is that you are capturing it earlier than the fluid production. You have that window of opportunity to prevent further damage. So I believe in future, TAE is going to change to OCTA guided TAE. That is, at every visit before you do your treat and extend, your OCTA is going to be the tool to see whether the fluid comes. You don't have fluid in TAE, but you're going to see whether the OCT recurrence has started, and that is going to refine your TAE to a great
No,
degree.
he beautifully told about the signs on OCTA, the fringes, anastomosis, and now even there is an open circuit and closed circuit pattern. The closed circuit pattern is more resistant actually.
Okay. He's ready, so.
Ready?
We now invite Dr. Naveen Sakhuja. He will be speaking on digital workflow for diagnosis and management of retinal disease.
Thank you very much, everybody. So I'm going to start a little bit to do this 7-minute race to try and finish whatever I can tell you about this digital workflow in retinal disease. Now, we all know that basically there are multiple tools available to all of us, and every one of us is already using them, where we use multiple methods of different technology to either diagnose, prognosticate, manage, or monitor disease. I'm not going to go through the modalities, all of us already know them, but I'll tell you basically I'm going to talk to you about the way we run it. We run a small but busy clinic within Delhi, and we first and foremost register the patient. All our registration is linked to Forum. Forum is a software provided by Zeiss and allows us that once the registration is done, we don't, each technician does not have to re-enter the data again and again and again into different machines, which is upsetting for both the patient as well as for the technician. It takes up more and more time. Subsequent to that, the patient is immediately shifted to a refraction. If the patient is not improvable to 6/6, the consultant is called in and we start the dilation process right there so that the patient doesn't have to be have to wait to be started. Subsequent to that, the patient reaches the consultant where all the data is already on the computer, and all the history, the examination, the plus 90D, the IOP, everything is measured by the consultant on a one-to-one basis with the patient, so that we are able to. A lot of information gets revealed when you talk to them. You know, in the course of conversation, they'll tell you how they originally had a breast cancer. And subsequent to that, of course, we are all the equipment is available to us to go ahead and do what we have to do. So we use the Octa 6000. It's a safe method. It's quick. It's great for follow-up. I don't have to inject the patient with dye each time. Coupled with the B scan, it shows all the methods of managing the patient. It allows clear visualization and allows us to see the choroidal lesions, as has been beautifully exemplified in the previous by the previous speaker. So I'm just going to talk to you about individual slides. This is a patient. On the left is a patient with a branch retinal vein occlusion, with you can see large areas of CNP on the left, and on the right is a patient with he's a one-eyed patient with proliferative diabetic retinopathy. Both of these patients were allergic to fluorescent dyes, so the method that we have used over here is we have relied on the OCTA to diagnose, prognosticate, and manage these patients. Here's a patient who's showing you where there's neovascularization visible, as has been shown beautifully in the last talk, so I won't go through in great detail about this. The other method we use for monitoring and looking after patients is the Claris 700, and I can say this without doubt that this is one of the finest machines that I have ever used for photography. It's just absolutely fabulous. With a small pupil, we get absolutely crystal clear views, and we get true color manifestation. We can also do an autofluorescence with it. Here is a guttering seen in a pachychoroid. Here is a stippled change that you see on pachychoroid again. Here, this is a patient who was originally diagnosed as being as a patient of papilledema. She had been to 2 other doctors. It was basically blurred disc, and they had been carrying on with that, and the OCT showed no cupping and as well as elevation. But a simple thing like the FAF showed up, the thing is an optic nerve head drusen. Here's a FAF in AMD, both blue and green. With that, we come to fluorescent angiography. We use a wide field fluorescent angiography. Primarily for diagnosis, it's not really something that we use on regularly for follow-up because you have to inject the patient again and again. But in certain situations, you need to, and I'm going to come to those just now. This is just to show you an image of what the Claris shows as a true color image. Here's a patient of severe, really bad case of CRVO. Here's a patient of Coates disease, where you can see the little circle in the center shows you what conventional fundus imaging shows. Here's a patient of vasculitis, and here we had to use fluorescent angiography to monitor her again and again because we wanted to see the image, see whether she improved, and she did not improve with oral steroids. She finally improved only with Ozurdex. Here's another patient who just reported to us recently with hypertensive retinopathy. And frankly speaking, when we saw her originally, we were wondering what it is, but we checked her BP, had a look at her, and she showed a typical picture of hypertensive retinopathy. Here's diabetic retinopathy. Now, this patient came to us from out of town, and if you really look carefully, you can make out that there are changes, but otherwise it's a fairly bland-looking retina. And here is the angiogram. And this patient was another patient where, for the workflow, we had to follow up the patient again and again with angiography. This is the angiogram after the anti-VEGF injection, and we've started the PRP, as you can see. Here's another diabetic retinopathy, and here's a patient with macular dystrophy. I just overheard someone talking. She's going to be talking to us in great detail about macular dystrophy subsequently. This is another patient with pachychoroid again. Now here we've used multiple methods to monitor, to look at this patient, and we have you can measure and see that in the subfoveal area you've got a thickening of greater than 300 microns. Here's a patient of a BRVO where the method of monitoring for the workflow, here we've used just the OCT and the angiography, and you can see the amount of fluid that is accumulated there. This is a patient with an old patient of BRVO. I mean, she's had BRVO for a long time. We've given her multiple injections, and the follow-up is usually being done for her by OCT alone, which is showing a improvement in the subsequent in the slide on the right. This is a patient who came to about to finish.
One more minute.
Yeah, just two more slides. This is a patient who's shown an improvement. The green ones show you after we've injected her with Pagenex, and the initial injections were all with Eylea. This is one of the things we use regularly to examine patients in the retina workplace, where we are able to superimpose images of the OCT on the fundus image and able to monitor them to see what we need to see to sort of register it on that thing and see what we are trying to look at on the fundus image. I'm not sure this is showing up or not. Yeah, there it is. You see what it looks like on the video. This is another patient. You can see the 2-3 serial studies are registered, and so you can see that the improvement takes place over here on the after the injections. So finally, I want to say one thing that I want sort of as a takeaway is that one must be very mindful of over-investigating. All of us have lots and lots of equipment and lots of methods of investigating these patients. There's a financial implication both on the side of the doctor as well as on the side of the patient. So as far as possible, try and tailor-make the investigation to the patient's disease. Thank you very much.
Any questions from the audience? No, I think anybody would like to make this workplace, is it a software that is into which system? Into your EMR?
See, the EMR, I use an EMR from Bangalore called EHNote, and the EMR is linked to Retinal to the software provided by Zeiss called Forum. Forum is a sort of server in which all the machines are linked. That means Claris is linked to it, and the OCTA is linked to it, the field analyzer is linked to it, including the phoropter is linked to it. Now, every time I want to retrieve data, I can retrieve directly from Forum. Retina Workplace, they have a Retina Workplace and a Glaucoma Workplace. I don't use Glaucoma Workplace. Retina Workplace allows me to, moment you put the image of the OCT, let's say of the OCTA, onto the color image, it registers on the color image. So that means all subsequent images you are seeing exactly the same area, and you're able to follow them up like that, like the way I showed in the last video.
Okay, so that simultaneously it plays the first time.
Yes, yes, yes.
Okay. So I think thank you very much for bringing up this. Thank you.
Thank you very much, everybody.
Dr. Ronald Sobran, he will be presenting on important OCT biomarkers.
Good morning, all. My presentation is on important OCT biomarkers. It is useful for diagnosis, measuring disease progression, or predicting and monitoring effects of therapeutic interventions, and it is great importance for individualizing the treatment. So OCT biomarkers is non-invasive, provide near histological assessment, and is very useful in assessing the functional outcomes. In this vitreomacular interface disorder, here you can see it can be divided in central bouquet abnormalities, which can be divided in OCT. You can see here the cotton ball sign appearance, and the second stage is the foveolar detachment, and the third one is the aqueous-betaliform lesion formation. Here, this cotton ball sign is nothing but this round is fuzzy hyperreflective area between the inner segment ellipsoid joint and interdissection zone. Here you can see this round is fuzzy appearance. So next important biomarkers is the ectopic inner foveal layers, which is usually seen in epiretinal membrane in third and the fourth stage. Which is or hyperreflective bands extending from the inner nuclear layer and inner plexiform layer across the foveal area. So these two structures, first is the aqueous-betaliform lesions and ectopic inner foveal layers. These two structures, before the appearance of these two structures, this indicated that if you perform the surgeries before the appearance of these two structures, the structural as well as the functional improvement is complete. So some of the OCT biomarkers in uveitic disorders are the bacillary layer detachment. Here this separation, you can see here in these OCT pictures, here the separation of inner segment of myoid zone from the inner segment of this separation you can see, which is usually seen in Bok-Yarnaki Harada or Toxoplasma chorioretinitis. And another OCT biomarkers for syphilis placoid is the acute loss of, you can see here in the syphilis placoid disease, here the loss of EZ and the thickening of the RPE, and with the nodular elevation here you can see the loss, which is completely resolved after the treatment. So another sign which is Pitchfork sign. So it is the, you can see here the finger-like projections from the towards the retina, outer retinal layers. Here, this is usually seen in syphilitic lesions, toxoplasmosis, tuberculosis lesion, and inflammatory CNBM, sometimes in inflammatory CNBM also. Another sign you can see here is the Ren-Cloud sign, which is first described by Invernizzi et al. In the patient with the endogenous Candida anophthalmitis. Here you can see the hyperreflective echoes in the retinal surface with the backscattering towards the choroidal side. Some of the OCT biomarkers in the disorder which are seen in drug toxicities the flying social sign, which was first described by Chen et al. In hydroxychloroquine retinopathy. Here you can see in the perifoveal area, the loss of EZ in the perifoveal area, and which is present in the EZ in the foveal area. So another OCT biomarkers which we can see in the MAC inhibitors associated retinopathy, which is usually transient and self-limiting retinopathy, which can be of 4 types, the 4 distinct features which can see in these MAC inhibitors associated retinopathy. One is dome shape, one is caterpillar like arrangement, and one is wavy-like arrangement, and then it's a splitting type, which is usually transient and self-limiting retinopathy. So OCT biomarker, which we can see in the neovascular AMD, can be divided into distributions of retinal fluid or structural arrangement. So in the distributions of retinal fluid, we have an intraretinal cystoid fluid arrangement and subretinal fluid and sub-RPA fluid. Here you can see this intraretinal fluid, which is usually the pro-prognostic sign, and subretinal fluid here you can see, and this sub-RPE fluid here you can see, this area, this sub-RPE fluid. So structural OCT biomarkers in AMD are the photoreceptor layer integrity. In this photograph of OCT, you can see here the disruptions of...
you have 1 minute to conclude.
Okay, sir. Which is prognostically very bad sign. And another finding is the hyperreflective dot in the which is related with activity and the lesions of its recurrence. So one important sign is the outer retinal tubulation, which was first described by Jevifil in 2009. It is a hyporeflective structure. Here you can see this is the outer retinal tubulation. Presence of this is usually the worst prognosis. And another is a subretinal hyperreflective material. Sometimes it is also known as subretinal hyperreflective exudate, which is located
in...
You
need to conclude now. Its time is up.
Yeah. So actually, take-home message is thorough understanding of these biomarkers is important because of their diagnostic and potential prognostic and predictive value. Thank you.
Thank you very much, sir. It is a very enlightening talk. So what would be the approximate time duration between stage 1, 2, 3, 4 of epiretinal membranes that you said? Approximate time durations for progression from one stage to the other. You said in stage 2, till stage 2, you have very good results.
Yeah, actually around about 6 months to 1 year or something.
All right, okay. And in AMD, which you showed all the biomarkers, intraretinal, subretinal, sub-RP, which is the most critical fluid that you consider for repeat treatment?
The sub-RP one.
Okay, 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 okay.
Any other questions from the audience? Okay. Otherwise, thank you very much, Ronel. And I invite Dr. Vishal Agarwal. He will be speaking on the role of ultra-wide field imaging in everyday practice.
Sir, next presenter will be ready there. Vishal is connecting the laptop.
Next speaker, if they are ready, yeah. No problem. I think Krishnendu Nandi is here. Yeah, okay. You be ready with this. Okay, thank you.
I'm ready, sir. Thank you, everybody, and good morning. I'll be speaking on the role of ultra-wide imaging in everyday practice, and specifically, I'll be using my experience in this presentation of the broadline fundus imaging, which I use regularly. So just brief about the basics. Standard fundus photography, as we all know, is 30 to 50 degree image, limited to the posterior pole. And even in the ETDRS, where they montage 7 standard field images, it led to a field of 75 degree. The retinal periphery, for a very long time, still couldn't be adequately visualized. So we have a nomenclature now, which says that posterior pole is 50 degrees, and 60 to 100 degrees is classified as wide field, and more than 100 degree is far periphery. Pan-retinal, that is 360 degree, is still in the making, and right now no machine can capture the image of an entire retina. So this is the UWF of the Claris I use, and these white circles are the ETDRS, that is 75 degree, and you can imagine how much area we were missing previously, even after montaging. So a small slide about the optics. So it's a white light, it's a broad rectangle of light. It is scanned across the retina, and it is detected using a monochromatic camera. And there are 3 LEDs, red, green, and blue, and that leads to a true color image. So the concept here is by using a slit to illuminate a portion of the retina, not a flash, the broadline fundus image limits unwanted scattering and reflections with, as compared to a flash-based camera. So apart from a wide field photo, it gives you angiography, it gives you, autofluorescence, external photo, and of course, various filters, red, green, and blue. And the color is actually what you see on a 90D or an indirect examination. So this was a disc edema, and after a posterior septinal steroid injection, you can see the change, and you can see the clarity and the margins of the disc, almost as true as what you see clinically. So coming to the clinical cases, as I told you, it is a multimodal imaging system, and it has both blue and green autofluorescence. You can see the images here, and of course, coming to the vascular disorders, this was a proliferative diabetic retinopathy. You can objectively quantify where the areas you have left after PRP, and if you want to augment, you can see the CNP areas or the skip areas and magnify them and do a targeted laser therapy. Again, an image of proliferative diabetic retinopathy. Here you can see the 200-degree view of this system and the fanning of vessels, which is more clear without even an angiography on the red-free photograph, and you can see all around a florid neovascularization on this image. And again, a targeted approach is very helpful rather than barraging the whole retina and limiting the field of view of the patient. So these photographs, what I'm showing you, are all for this presentation undilated photographs. The patient comes in, gets an ultra-wide field photograph, and you can see the extent of retina we can imagine. So this was he was a doctor, he was a dentist, and he came with sudden onset of floaters. The vision was 6x6, and you can see there's a nasal large horseshoe tear with a little amount of vitreous hemorrhage, and we barraged the patient. And for prognostic purposes also, this patient is a 40-year-old female with Stickler syndrome. One eye I had operated, and the second eye also got a detachment, and the patient was 6x6, and the patient denied surgery because he said, I have no problem in my vision. I'm just seeing a shadow, and I'm just seeing some floaters. And 3 days after, when the macula was involved, you can see the vision dropped, and she came running again that I need a surgery immediately. So you can prognosticate. You can tell the patient that I told you, of course I will operate and the retina will get attached, but the prognosis remains fair as compared if I had operated on you 3 or 4 days back when the macula was on. You can evaluate your pre and post-ops. This is a giant retinal tear, and this is the first post-op day with the undilated pupil. You can see the laser marks, and you can see check for residual fluid or skip areas if you want to augment laser in these cases. And this is the clarity which it gives you even in post-op day 1 when the media is slightly hazy. Post-op buckling patients, you can see the pediatric patient with multiple lattices and holes, and you can see the buckle effect and the cryo effect in these cases. So these are very interesting cases, when you are operating on high myopes or in choroidal detachment cases, and then you see in the post-op period. So this shadow is actually not an artifact. This is basically signifying the underfill of the silicone oil. And in these cases, you have to be careful to, examine the inferior periphery in the follow-ups and to augment laser wear, because these are prone to recurrences because you have an underfill of silicone oil in these cases. Coming to inflammatory pathology, multifocal choroiditis, Ozurdex implant in place, all undilated photographs, and you can see the post-Ozurdex follow-ups. The areas of the active choroiditis have been resolved, and you can see the crumpling and the absorption of drug from the implant. And coming to the angiography, if you use a 40 or 50 degree camera of the posterior pole, you can easily miss the CNP areas in the periphery, like in these cases of vasculitis, and you will not laser them, and they might turn up with neovascularization or vitreous hemorrhage in the follow-up periods, because you never knew that these CNP areas existed in the periphery with conventional angiography systems. This was a patient, a 10-year-old girl who presented with sudden vision loss, and the parents came, and this was, there was a CNVM in the posterior pole, 10-year-old girl, and when we did an angiography, you can see in the far periphery, nasal as well as the temporal, you can see these inflammatory leakages, and it was an inflammatory, post-inflammatory CNVM. Patient was injected with the anti-VEGF and did fine. Coming to these cases of post-op period, this was a macular hole operated. The hole was closed. It was a type 1 closure. The patient was not improving beyond 636. It was so if you use the blue channel, you can see all these marks around the fovea. This was an optic nerve fiber layer.
You have 1 minute to conclude.
1 minute, sir? Just concluding. So you can prognosticate the patient, and a recurrent vitreous hemorrhage in a 50-year-old female, no cause was seen. We did an angiography, a temporal vasoproliferative tumor was done, a cryo and laser was done, and the patient did fine in the post-laser period. So pediatric imaging is a slightly skillful job, but it takes only 3 or 4 seconds. Leber's miliary aneurysm, you can see the CNP areas, and this one was the recent. The patient was a 6-month-old male with tuberous sclerosis, and you can see the retinal hematomas. It's a 3-second click, and you can get a wonderful picture of the posterior pole. So to conclude, indirect ophthalmoscopy still is the gold standard, but this is the true color imaging. Ultra-wide field is the next best thing, maybe better in some cases, because indirect is a poor and a subjective documentation. It's difficult to implement in a heavy workflow. You cannot do justice in every patient. There are dilatation problems and long waiting times in a heavy OPD. So the BFI advantage of ultra-wide is that it is a game changer in the future of ultra-wide field imaging. Aids in observing, documenting, and treating areas. And it's an excellent adjunct to pre-operative cataract workup also, and for the counseling of the patient. Excellent HD resolution, near zero artifacts are the major benefits. Of course, the caveat is cost. Cost is still a prohibitive factor. Thank you.
Excellent, Vishal. But now, I think recently the Seva Foundation has sponsored a camera for Remedio, and they made a ultra-wide. I don't know.
Yes.
I have to see in the exhibition available, but I hope the cost will come down. Definitely, I think the ultra-wide field will be to go to the future.
Yes.
Yes. Dr. Vishal, you have wonderful collection or album of varieties of retinal images in the wild field images. Can you tell the audience what difference it made in your practice after ultra-wide field imaging and before that?
Huge difference, sir, because if especially in a high volume retina practice, I cannot, there's a human fatigue factor in every patient. I cannot do the same meticulous indirect in my first patient and the same meticulous indirect in my 60th patient. So sometimes, you tend to miss things, especially in uncooperative patients. Sometimes the technician also says, sir, ye hole dikh raha hai supratemporal quadrant mein, and you again see the patient, and actually there is a hole which you missed because of a fatigue factor. So you have to, be objective in documentation, and this helps a lot in that case.
Thank you.
Any questions from the audience? If no questions, then we will invite Dr. Krishnendu Nandi. He will be speaking on ICG angiography.
Yeah. Good morning, everybody. So my presentation is little old presentation of ICG is rarely practiced nowadays. So why we do need ICG? Because of these things, because this case, first one case is a block fluorescence because of the blood, and doing ICG will reveal the polyp. Again, the second case showing the hot spot in ICG. So this patient has to be treated. So we have to diagnose the cause. The first ICG was used in measuring cardiac output 1957, but in its digital practice in 1992 in ophthalmology. So properties is everyone knows the most important thing is a high plasma protein bound, about 98%, which has its work in infrared region, and that is most useful for us. Limitation, the limitation of FFA, which we cannot study the choroidal circulation by FFA, that can be done by ICG. Advantage of the ICG, we can see the lesion which is being obscured by the ocular pigment and hemorrhages, relatively safe dye, and doesn't have very high side effect. Adverse effects, nausea, vomiting is all cases, and severe anaphylactic shock often lessly encountered. So angiography, there's the early phase of angiography. Early mid phase, there is 1 to 3 minutes. Late mid phase, this is the most important phase, 3 to 15 minutes time. And late phase, 15 to 30 minutes. So very important terms we should know: the hotspot. Hotspot is an area of abnormal intense fluorescence in the mid and late phase of ICG, but size should be less than 1 Dix diameter. And plaque, the size is more than 1 Dix diameter. The polyp, this lesion demonstrate intense focal or multifocal spots within 6 minutes of ICG angiography, but this has to be treated. RAP, the difference is the same, is a single hotspot, not multiple, and the timing is same mid and late phase of ICG. The indication of ICG, mainly the occult neovascularization, IPCB mostly, RAP lesion, and CSCR often present with CNVM. Inflammatory conditions, some choroidal inflammatory condition, some cases of choroidal hemangioma, and ICG enhanced laser photocoagulation is an indication. This is a case one where the patient, if it doesn't show anything, the ICG shows hotspot, so we have to treat nowadays with injection, previously with PDT. This is a case. Second case, this is a case of block fluorescence, lot of block fluorescence in FFA, but ICG, this is a camera-based ICG, shows there is a 2 hotspot at the supratemporal quadrant, which is actually treated with a focal laser. And after 6 months, again the patient presented with the leakage somewhere else, detected in ICG. This is a peripheral leak. Again, we can do the focal laser, but in addition with the injection because of the subretinal fluid, and patient received 2 injections subsequently. The most interesting thing is the peripheral PCB. You can see the peripheral polyp in the supratemporal quadrant of the same patient. And we can treat this thing with a laser and pneumatic displacement with injection. It's a case of RAP lesion. You can see the retinal choroidal anastomosis, and this usually treated with PDT. There's a case of CSCR, 636 vision. Why we do FFA? Because to see the central leak. Previously, we has to be treated. If it is a chronic for more than 6 months, then we can treat with the PDT. Nowadays, we often observe. And after resolution, after doing PDT, the vision improved to 6.9. The RAM lesion, often we cannot see the leakage actually. The ICG will point out the leakage in RAM lesion. There's a case of choroidal hemangioma. Before the dye appears in the circulation, we can see the tumor lesion quite easily. And after PDT, everything resolved. Choroidal inflammation also a great role to play. Mostly the choroidal inflammatory mediators, often it shows the extensiveness of the disease. Often we can be missed by clinical examination and FFA. More extensive the disease, more poor the prognosis. Even with the steroid therapy, the multiple hypofluorescent spot which can be seen in ICG is reduced with time. So these are the example of AMPP where a lot of hypofluorescent lesions are seen in ICG. Punctate inner choroidal lesion, again the same, the hypofluorescent lesion in the ICG. Azure, again the same, we can detect the azure lesion in ICG. Now, therapeutic uses of ICG, mostly the PDT, in the era of PDT, there is an essential need of ICG. Nowadays, it is hardly in practice. See, this is the area of polyp. The whole area has to be done with a PDT lesion and everything is gone. The role of video ICG to demonstrate the dynamic presence of polyp. Here you can see there's a polyp lesion here and with a branching vascular network. So advantage of ICG, we can detect polyp more easily than the OCTA, though it is invasive. But nowadays is hardly in practice because of non-availability of PDT in many centers. So in conclusion, ICG is still useful in some cases where the FFA doesn't give any role or OCTA fails to give us any polypoidal lesion, and also in cases of CSCR presented with CNVM. Thank you for your patience hearing.
Thank you for being on time. Dr. Judge.
Yeah, thank you, Dr. Krishnendu. And, you spoke about ICG in PCV versus RAP, actually. Beautifully pointed. The point to highlight here is both have nodular hyperfluorescence or hypercyanescence, but the timing, early versus late, is one of the important differentiating features where you have the early in one and the late nodular in RAP lesion, other than the retinochoroidal anastomosis that we see in RAP lesions. And I would disagree that RAP PDT is no more a choice of treatment, because it will affect, if there is a retinochoroidal anastomosis, it can injure the retina if there is a retinochoroidal anastomosis. So PDT is no more an option in RAP lesions. And to extend to what Dr. Vishal had highlighted on ultra wide field, he had shown, but now we have ultra wide field. Beautifully he showed the fundus photographs, but then now we have the ultra wide field FFA and ICG as well. So I would just like to highlight that in fluorescein angiography, 3 indications where the ultra wide field FFA would be particularly useful is the peripheral vascular lesions in diabetic retinopathy, in 10% of the diabetic retinopathy on ultra wide field, and in RVOs as common as 40% in the peripheral vascular, which you don't pick up with the normal up till equator fluorescein angiography, and peripheral vasculitis in fluorescein angiography. ICG, ultra wide field, especially in peripheral exudative hemorrhagic variant of the PCV. So, and even in CSC now, the ultra wide field ICG is very important.
Yeah, thank you. I think that's what I...
Thank you, Krishnendu. Now we will invite Dr. Anna. She will be speaking on clinical applications of OCTA in AMD. And is
Hello.
Peter Haddon is the...
Sorry.
Yeah, please. You will be the next speaker. Yeah.
Hello, thank you so much for having me here. It's my first AIOC in person. I've done a lot on webinars, but it's so nice to be in person here in India to talk to you about OCTA and AMD. I think the previous speakers already introduced OCTA. We know that, OCT has really transformed our clinical management all the way from the days of time domain all the way to swept source now. And you know that in AMD, we have it's not a new classification anymore, but instead of the fluorescein classification which was used to, we now classify AMD according to the histological layer of where it is in. So in the type 1 neovascularization, it's below the RPE, and as type 1 can also occur with PCV, and of course we have type 2, which is above the RPE, and of course type 3 or RAP that we were just discussing before. And I don't need to really introduce much about OCTA because I'm sure everybody in this room in the retinal subspecialty knows about it, but it really has transformed the way we do angiography, whereby now we do not need dye anymore, but we can still see the blood vessels. And here I just give you a overview of how I interpret OCTAs, especially if you're starting. This is a good overview on how you can look for the area of interest on OCTA, and because OCTA as a technology is only useful if you are able to be good at OCT and you are looking for the area of interest. Let's go into some of the AMD lesions. This is a type 1 neovascularization. As you can see in the multimodal imaging, you have an occult leakage picture on FFA and a plaque on ICGA. When you then look at the cross-sectional OCT, you see a multi-layered PED. And this is very indicative of a neovascularized PED. And when you do the cross-sectional OCTA, you see flow is indeed in the contents of the PED, and that flow translates into a membrane membrane that you can see on fast OCTA. So what are some of the features of type 1 neovascularization? Already, as mentioned by the previous authors, there's some patterns that you can notice, the Medusa and the C-fan pattern, and that's especially important implications for response to treatment. You can see in this study where I did when I was in the US in New York, you can see that when we compare the different modalities of looking to see whether we could detect a type 1 neovascularization, if you combine OCTA and OCT, you got an 85.7% of detecting when you use this compared to traditional multimodal imaging with fluorescein and OCT. And really, OCTA also has limitations. So some of the limitations include when the PED is too high, or there's low signal strength, or sometimes in treatment-naive disease, you may not see the type 1 membrane as much. When you look at the comparison of OCTA versus ICGA, you can see that in ICGA, because of the leakage, its area is usually a bit larger than the OCTA image when you look at the OCTA and the vessels itself, because there's no leakage on OCTA. And the important thing, as we mentioned before, is OCTA allows neovascularization to be monitored in response to treatment. And you can see in this case, after 3 aflibercept injections, some things happen, and you can see the size and the density of the lesion decreases. In lesions that are chronic, you can see there's a prune tree appearance, and all the peripheral vessels, the small peripheral vessels and the anastomoses actually go away, leaving a more stable membrane. And this is important because a stable membrane, as mentioned before, actually leaks very little and it helps prevent against atrophy. And we should be aiming for a stable membrane if you can't get rid of the membrane altogether. Type 1 and PCV is also importantly seen here. You can see a peak PED and a branching vascular network here. The peak PED is where the polypoidal lesion is, and the branching vascular network is next to it. And we know in OCTA that the cross-sectional OCTA helps us to find the polypoidal lesion. However, the on-fast OCTA can miss the polypoidal lesion in about 75%, and only in 25% you get to see the hyperflow lesion. However, the BVN is often seen quite well. And you can see in this case, we also have polypoidal lesions diagnosed on OCT and OCTA. And you can see that quite a lot of characteristics on OCTA can already tell you with quite a lot of certainty whether there's a PCV or not. Tomorrow, I will delve more in depth to it. At the same time, tomorrow, I will have another talk to really tell you a little bit more about how OCT and OCTA can help you not only diagnose PCV, but look at PCV response to treatment. I'll go on to the next case, and you can see the type 2 neovascularization when there is a lesion above the RPE, and it's looked as on OCT as a subretinal hyperreflective material. You can see when you do OCTA, the flow is within the SREM, and then you can see a nice membrane over there. And you can see the flow is above the RPE, and there's again different patterns that you can see. And the dark halo around is actually a specific sign which is indicative of activity on OCTA. Again, response, you can see there's fragmentations of the peripheral vessels. They then form a very much more stable configuration and a prune tree appearance. And you can see even when they did OCTA at day 1 all the way to day 32, you can see the reason why we start needing to get injections at month 1 is because the lesion regresses but starts to reform by the time you get to day 32. And as rightly pointed out by previous speakers, you may be able to see recurrence of the vessels even before the leakage happens on OCT. And this is the same for type 3 neovascularizations. It's quite specific. And on type 3, the actual OCT on the cross-section OCTA is what helps you diagnose a type 3, because you can see this linear hyperreflective flow signal, and this is where the type 3 lesion is. And on fast, sometimes it can be missed because it's quite subtle. And you can see in response to anti-VEGF, we published a very early paper when OCT came out, and you can see the recurrence often happens happens even with the OCTA membrane growing even before it starts to leak after that.
You have 1 minute to.
No problems, thank you. And you can see I mentioned before, these are features of an active CNV, and there are features of an inactive lesion. And the hypo area around it, as well as the branching tiny capillaries in the periphery, and the presence of the vessel termini, all are signs of active lesions. And 90.5 correspond that lesions that do not need treatment if you look at the prune tree appearance. And the quiescent CNV was also a topic of conversation, and you can see that we do detect them now before they leak, and if not, we do not still treat them as when they are quiescent. However, we should increase our follow-up period, reduce our follow-up period and monitor these lesions more closely, because the risk of leaking is much higher than those PEDs that are not vascularized. So I just want to finish up with some summary. This is a paper that we published anyways, and you can go read it because 7 minutes is no time to finish. But anyways, we know that OCT allows the differentiation between flow and other hyperreflective structures. You can see that it can be used to classify PEDs as well as look at the different types of AMD. It is an easy, non-invasive method of imaging, and cross-sectional OCTA is useful for a screening tool. It provides information about flow and can help determine activity. And OCTA and structural OCT are comparable to angiography now to identify a lot of neovascular AMD. And quiescent CNVs can also be detected before active changes appear. With that, I want to invite you to APVRS in Singapore and our Fellows Advanced Surgery course. And I thank you so much for your time. And I am on time, I think.
Thank you.
Yeah, thank you very much, ma'am. It was indeed a very good presentation and very well presented.
Great.
Such a vast topic. Finishing in 7 minutes was a great task, and you have done it very well. And we would like to hear you again tomorrow.
Great.
Just one question. Actually, you have discussed everything in detail. Just one question. In SNEC, it's a big institute. What do you see in the trend in last 4-5 years? Has the dye angiography gone down drastically, or you're not doing it at all?
I think so. What I tell initially when OCT came on, we're a bit cautious. We still always wanted to back it up with fluorescein and ICG. But I think as the technology has gone, and now we've been using it for about 4 to 5 years, I think when it's really obvious and you see the neovascularization when you do the OCTA, then you can be confident you don't need to do a fluorescein, because it's not going to tell you much more information. This is in typical AMD. For PCVs, however, because a lot of the polypoidal lesions can be missed, I think for PCVs, the ICGA is still important. However, when the lesion is not found on the OCTA, then I think you definitively cannot say it's not there, and I think you do need to back it up with angiography.
Thank you. Thank you very much, ma'am.
No problem.
Thank you, Anna. And now we will invite Dr. Peter Hayden. He will be presenting on utility of multimodal imaging in retinal diagnosis. Dr. Peter.
Good morning, and thank you. My slides? Yeah, thank you. So multimodal imaging is, of course, the use of more than one technique to complement each other. So first, let's look at photography. So photography has many uses, one of which is remote diagnosis, for instance, in diabetic photo screening. I also, for instance, run a virtual multimodal imaging tumor clinic in which I review the images of patients without having to see them to rule out benign lesions such as this nevus, which is seen here to have no fluid on the OCT and relatively dark on autofluorescence. Adding a red filter, it has gone. We also have wide field cameras, of course, that have much improved our ability to visualize the periphery and large lesions such as this tumor. Adding a red filter can image choroidal lesions better, while red-free photography is especially useful to highlight red-colored lesions such as hemorrhage and diabetic retinopathy. Many modern cameras, of course, also do fundus autofluorescence, which detects lipofuscin and other fluorophores, and which also enable it to detect subretinal fluid, for instance, in this peripapillary uveal melanoma. It also can be used to follow diseases that affect the RPE, such as serpiginous, which you can see here followed very easily with autofluorescence. And chirpies are characteristically very dark, and again, obvious on autofluorescence. Photography can also allow the sharing of problem cases, of course, too. In the South Pacific, we have a WhatsApp group the Pacific Island doctors can use to get advice from Australian and New Zealand ophthalmologists, and I can also ask colleagues overseas for advice on some of my cases. And finally, serial photography can sometimes clinch the diagnosis, such as in this UV or melanoma. Of course, we can't forget fluorescein angiography as well. Another form of imaging we use is OCT, of course, which is used in the retina mainly in two ways, either to map a relatively large area, for instance, showing generalized thinning from a branch vein occlusion, or provide slice-by-slice images of very localized pathologies. You can, of course, also alter the color to allow easier visualization, and if you want to image the choroid better, you can do it with enhanced depth imaging. As we saw in the last talk, many machines also now support OCT angiography to allow non-invasive visualization of the circulation. The other part of the multimodal imaging platform is ultrasound, of great use both in tumours to allow you to measure the size of the tumour and characterise its echogenicity, and also, of course, imaging the posterior segment in the setting of media opacities. So let's look at some examples. So here is a typical choroidal melanoma with multimodal imaging confirming the classic suspicious features of thickness, fluid, lipofuscin, and ultrasound hypoechogenicity. Some can be associated with a serous retinal detachment, which you can see in the lower right shows up very well on autofluorescence. And then you get some strange ones, such as this one, which is associated with a cyst, which you can visualize both on OCT and ultrasound. But that's typical choroidal melanoma. Here's another dark tumor with a lot of exudate around it, which is a little unusual, of course. And when you do autofluorescence, you find it's very dark, and there doesn't appear to be much autofluorescence. Then when you look at it on OCT, enhanced depth imaging, it's not really in the choroid either. And as opposed to that previous melanomas, this one's somewhat hyperechoic on B-scan. So this is not a choroidal melanoma. And luckily for us, by chance, some years later, we managed to get histology on this eye, thanks to another issue. And it confirmed it was not a melanoma, it's adenocarcinoma of the RPE. So here's another lump in the peripheral retina, as someone mentioned, well imaged with Optos. We do an OCT through it, and it shows a large pigment epithelial detachment, which of course suggests a peripheral exudative chorioretinopathy. And this was confirmed, multimodal imaging again, with shrinkage both on OCT and photos some 3 months later. And another case, this is Sjogren-Larsen syndrome with a crystalline maculopathy. And these crystalline deposits show up very well on autofluorescent on OCT, while the autofluorescence shows a much more generalized pathology. And this white choroidal tumor with subretinal fluid, you can see it's in the choroid, it's associated with subretinal fluid, but it's white. When you do multimodal imaging and you look at the ultrasound, it has obviously very hyperechoic with an acoustic shadow, and quite clearly it's an osteoma. And thank you.
On being on time, and now Dr. Somu, can you discuss?
Thank you for the image. Thank you for lots of these images, sir. So my question would be that let's say there are patients. Let's say there's a patient of PCV that comes to you. Would you be doing the multimodal imaging? Let's say you do the OCT first, or do you go ahead in the first?
I should say that I'm a vitreoretinal surgeon and do ocular oncology. I don't do medical retina, I'm afraid.
I saw a lot of your autofluorescence and infrared imaging. What would be your, best indications for autofluorescence versus red-free or infrared imaging?
I do autofluorescence routinely on all my cases, which are tumours and vitreoretinal cases, but mainly talking about tumours. As for red-free, I don't use it very much.
Okay. Thank you very much. Now we will invite Dr. Manvi Sindar. She will be speaking on differentiating PCV and wet AMD.
Good morning, everyone, and I think a lot of my work has already been done in parts by the prior speakers. I think I'll just bring it all together. So, as we know, AMD is one of the leading causes of loss of vision, and we see quite a lot of PCV, especially in our population. It's more of a vascular disease of the choroid and is characterized by the recurrent serosanguinous maculopathy, presence of orange nodules, and pachychoroid. And what differentiates it from AMD is the absence of drusen, pigmentary changes, and atrophy. We can use all the various imaging modalities in different ways. Let's go through them. So fundus photography in PCV, you would see an orange nodule, the pigment epithelial detachment, which could be a hemorrhagic PD or a serous PD, extensive subretinal hemorrhage, and lipid deposition. On the basis of this, clinically, PCV is classified into the exudative form, as is seen in the first image over here, where there is more of exudation and more of fluid and lipids. The hemorrhagic form, which can have the hemorrhagic PEDs or the subretinal hemorrhage, and a mixed form of the two. We should suspect PCV clinically when you are seeing the orange-red subnodular nodule, serosanguinous maculopathy. Here you can see in this case you have a large PED. Here you have subretinal hemorrhage, you have sub-RP hemorrhage, a large lesion happening there. When there is disproportionately more exudation, and also when you have used anti-VEGF and there's a poor response to it. ICGA is the preferred modality of investigation for PCV, and the Everest has defined the criteria of nodular hyperfluorescence, hypofluorescent halo. So if you look carefully at this image here, you have the nodular hypofluorescence here, and this one here shows the hypofluorescent halo, and pulsatile, which can be seen in dynamic ICGA. In the first 1 minute of your ICGA for PCV, you will be looking at the branching vascular network, which is seen here in these lesions. And it is in the later 6 minutes that you look for the polypoidal lesions, which are noted over here in this particular eye. Let us look at this patient who was followed up over a period of more than a year, and this is the baseline ICGA, where you can see this is the branching neovascular network seen, and after a course of 14 months you can see that the whole network has expanded so much in size, and these are the polyps which were present initially, and when you look at later, there are a new row of string of polyps and a new onset PED which is seen now in this patient. So here with ICGA you can document the increase in the size of the BNN as well as the occurrence of the new polyps, since these polyps keep on appearing. On ICGA, it could be the macular PCV, which could be subfoveal, juxtafoveal, or extrafoveal. You could have it in peripapillary location, or it could be extra peripheral when it lies outside the arcade. Another example here is a polyp which is seen in this patient, which could be called either juxtafoveal or peripapillary, and here is a peripheral polyp seen in this patient. So the consensus nomenclature has been recently released, which has helped us define a lot of these terms. So one of the terms is that you have to use the term polypoidal lesion and not a polyp, because it's not a solid fleshy lesion, or aneurysmal, because these are not just dilated sub-RP lesion, may not always be present. The branching neovascular network, since this has seen to lie above the Brooks membrane, signifying that it is neovascular in origin, and the term complex or multilobular PED, which combines the previously used terms of notched PED and hemorrhagic or multilobular PED. These are the non-ICGA diagnostic criteria which this consensus nomenclature has described for us, and it has three major criteria. The first is the sub-RP ring-like lesion, the second is the en-face complex RP lesion, and the third is the sharp-peaked PED. You have minor criteria like the orange nodule, the thick choroid, the double layer sign, the complex multilobular PED, and the fluid component was also studied and evaluated but does not form a part of the minor criteria. Looking at these lesions one by one, you have the sharp peaked PED, which is the thumb-like PED or thumb-like protrusion, inverted V shape with a steep incline of at least more than 70 degrees on one side and a height as to width ratio of more than 1. You have the sub-RP ring-like lesions, which indicate the underlying polypoidal lesion. You can see that here as well as over here. The reflectivity in these may vary depending on case to case. The on-fast imaging, where you have the complex PD, these are the various polyps that you can see. This is from the same patient whose ICGA we just saw. These are all the different polyps, and this is the large PED that you can see on the on-fast image. The complex multilobular PED, which has what would be called as the notched PED, and you have the area of the double layer sign over here. And the double layer sign, which is the overlying RP undulating with an underlying Brooks membrane. This area typically represents or is the area where your BNN is going to lie, and you'd have your polyp here forming your complex or multilobular PED. And the pachychoroid, which is thicker for age and axial length, and you have a dilated Haller's layer. And the full fluid compartment, so there's definite more SRF than IRF seen in these patients. On the OCT angiography, the polypoidal lesion, the whole lesion has been described to lie in 3 layers. They have noted the polyps to be in the sub-RP space, the BNN on the outer side of the reference plane, and the feeder vessels from the choroid. Again, let us look at some octas. This is a BNN, the same patient we had seen in the ICGA. This is a baseline BNN, and you can see how it has increased. So the octa is also showing you the BNN increasing in size, same as you had seen on your ICGA. And here's another patient who I had followed up for over 10 years, and he's got this large branching vascular network. And if you look at his case history, he had this polypoidal lesion here, which went on to, which was treated. He had this PED here, multilobular PED. At this time, we couldn't image polyps. He went on to later on develop a PED lower lying over here. Then ICGA detected this polyps, which you can see lie at the junction of the older PED was at this area and the newer is here. So that was a very interesting finding. Went on to be treated for a long time, then developed fluid in the inferior temporal area, and that is when we saw in peripheral polyp also over here. The whole aim of showing this case is that these lesions can appear and regress in various areas with your treatment to appear in different areas in the same patient. So to conclude, polypoidal choroidal vasculopathy is very frequent in our population, and OCT signs may suffice to give you a working diagnosis and manage treatment. ICGA is, of course, very essential to confirm diagnosis, and for the Indian people, for when you need to do a focal laser for extrafoveal polyps, since unfortunately only some exclusive people have PDT available in India. Thank you.
So thank you, Manvi. I think that was a beautiful talk on PCV. In the current, or in your practice, I mean, majority of us now diagnose PCV quite reliably on OCT.
Absolutely.
So for the benefit of all of us, what would be the indications for ICG in a patient of PCV where you feel that without ICG you just cannot manage?
I would do ICG in a patient with PCV when I'm having extrafoveal lesions, which I want to do a focal laser for to reduce the treatment load, and for peripheral lesions. And sometimes if I'm having a very poor response, I may go in for an ICG. But since we don't have PDT, it's really not mandatory to do ICG. Otherwise, of course, you would need an ICG and to do a PDT and a combined treatment.
George?
Basically, I do agree because of the recalcitrant cases is where we currently do ICG, and when there are cases, at least 20% of them which do not respond to any anti-VEGF, even the new, so we combine it with PDT. I think currently we are doing it, but then with limited availability, it's still a challenge actually.
Thank you.
Thank you.
Yeah, now I invite Dr. Sandeep Grover. He will be presenting on ERG and its clinical applications.
Sandeep is Sandeep is working in. Sandeep is from Jacksonville and working on ERG for several years, and particularly I think his interest is inherited retinal degeneration. Welcome, Sandeep.
Thank you very much. Thank you very much for the scientific committee for inviting me. Can you hear me at the back? Okay. So we're going to talk about a very dry topic that was at the end, which is the ERG. Just curious how many of in the audience actually interpret an ERG. Okay, great. So just to make sure, these are my financial disclosures, but there's no conflict of interest in today's talk. So ERG is a great tool, but it really depends on how it is used. And when do we use it? Sometimes to diagnose particular conditions, sometimes to establish the prognosis, sometimes to kind of monitor the natural history of progression of a disease, especially the IRDs, and then in treatment trials as an endpoint. So sometimes you look at these retinal findings and can make the diagnosis. You really don't need an ERG for this, although sometimes you would do it as a baseline. But when you look at two conditions like this, and these are, the two look about the same, but they are two different conditions. So that's when you need an ERG to kind of establish a diagnosis. So what is ERG? It is basically the light falling on the photoreceptors, and the A wave, which is the first negative deflection, is from the photoreceptors, the rods and the cones. And then the electricity goes through from the outer retina to the inner retina, and that's where mainly the bipolar cells and the Mueller cell gives rise to the positive deflection, which is the B wave. And that's it. That's what ERG is. So dark adapt the patient for 30 minutes according to ICEF standards, and then you stimulate the retina with a dim light flash, and you get this kind of recording, which is totally rod. Then you stimulate with a brighter flash, and then you get the typical A and B wave, and that is rod predominant, although some cones are mixed in it. Then you let the patient light adapt for about 10 minutes, and then a single white flash. You get again an A and B wave there, and which is cones. And then you have a flicker, which is like the disco lights. That's what the patients say. And you get a maximal cone response, several peaks over there. And so basically you're looking at these four kind of ERG recordings to kind of make a diagnosis. So let's go through some cases. 12-year-old boy, unilateral retinal degeneration. Older brother was known to have Stargardt disease. Whenever you talk about unilateral retinal degeneration, always think about trauma, but there was no history of trauma. Vision was worse in the right eye, but even the left eye was slightly down. So that shows you a total retinal degeneration in that right eye. The left eye, relatively speaking, looked normal, although it was not normal. So you do an ERG, the top two are the right eye, the bottom two are the left eye, and dark adapted. So you can see there was hardly a ERG response in the right eye with diffuse degeneration. The left eye had what is called a negative ERG, where the B wave was not there, it was just the A wave. So negative ERG or selective B wave reduction. Of course, OCT makes a diagnosis nowadays, but you still need to confirm it with ERG as juvenile retinoschisis. Another 15-year-old boy, poor vision, poor color vision. You see the atrophic lesion in the macula, some flecks around it. Could be Stargardt disease, could be cone rod dystrophy. So you do an ERG, and what you see is, on the left is the patient and the right is the normal. So if you look at the photopic white for cones, you see the ERG is down quite a bit. You look at the red flicker, and you see the ERG is down quite a bit. So the cones are definitely affected. And then looking at the rods, they're down. They're not normal, but still better than cones. So this condition is described as cone rod dystrophy. This patient had cone rod dystrophy. If the ERG was totally normal, it would probably be Stargardt disease. Another patient, 40-year-old male, night vision problems for a long, long time, side vision issues, other family members with retinitis pigmentosa. You look at the fundus, hardly any pigments. You do have some pigments, but hardly any pigments. The vision was pretty good. The visual field was tubular in both the eyes. And when you do an ERG, you see it was totally extinguished, non-recordable. So the retina looked relatively good, but it established the prognosis that the field and the ERG are both down. This was actually an X-linked retinitis pigmentosa patient, X-linked family. Same, another 40-year-old patient, same retinitis pigmentosa, good vision, and these were the findings. And when you look at this and this, a lot of pigmentary change, mainly along the vascular arcades, better ERG. So you establish a kind of a better prognosis in this patient. And actually, 10 years later, the ERG was looking pretty similar, and the fields were looking similar. So it helped, it helped to establish the prognosis in this disease and to counsel the patient accordingly. 50-year-old, noticing some visual field problems for last 6 months and night vision issues. The retina looked pretty normal. But when you do the fundus autofluorescence, you see these hypo-autofluorescent patches like a ring along the vascular arcades and similar visual field.
1 minute to conclude.
Sure. And you do a light-adapted response. The cone responses don't look too bad, actually. But when you do the rod one on the left panel, it was pretty much non-recordable. And with the bright flash, again, you see the same negative ERG. You see the A wave, but the B wave doesn't go up. So one of the things to think about is to consider getting retinal antibody panel. Patient was positive on several retinal antibodies, and the diagnosis of autoimmune retinopathy was established, and had a full checkup. Thankfully, this is now 6 months, and so far the patient is negative for any cancer, but he's being followed for autoimmune retinopathy. 6 months, no progression. And the last case, 10-year-old, 1-year history of decreasing vision, poor vision in the right eye, not as much in the left, and ERG was done. The dark adapted response was pretty good. The light adapted was down, so the diagnosis of cone rod dystrophy was made. 6 months later or 5 months later, hand motion vision in both the eyes. Always, always, always think about in a young child about Batten disease, and we did the genetic testing, was positive for PPT1 gene, 2 pathogenic, and so that is why, and that's how the diagnosis is established. It's a fatal condition. So used for ERG in treatment trials. Just want to show we have a lot of trials at UF in the last 1 year.
Time is up.
And thank you.
Yeah, thank you for this talk and bringing up this topic. Nowadays, we have the genetic testing and even gene therapies coming in, it is extremely important to diagnose correctly before you go for genetic testing. And when you have a condition like the fundus, which you showed that annular pigmentary disturbance, it's very important that you diagnose whether it's an enhanced S-cone syndrome or it's a road cone dystrophy. Unless we get a good quality ERG, we cannot rule out. Second application, as you shown that heredomacular degeneration, macular dystrophies, you need to know whether it's a cone rod dystrophy or a Stargardt's. Just on when you don't see flex. I'm talking about all these borderline cases. It's extremely, extremely important to have and even for when you have a suspected HCQ toxicity, multifocal ERG is so important. So thank you for bringing up these issues.
So it's not a dry topic, and I think we keep discussing every year. So I run an inherited retinal degeneration clinic, and I insist on doing the phenotype, the pedigree chart, ERG, and correct interpretation, and then have a genomic test, and finally have a re-diagnosis of the clinical diagnosis.
Exactly. Unless you diagnose your clinically and electrophysiology, your genetic, you can't do the whole genome exome sequencing. You need to be more on a targeted for that particular patient based on whether you are suspecting a best orphanopathy panel or which panel you're going to ask, actually. It's very important in these days, actually.
The future of retina is going to be gene therapy, even though it's not right now. But for that, we need to be prepared.
We need to understand the electrophysiology first, actually, properly.
Thank you.
Thank you, Dr. Grover. With this, we are concluding the session 1 of Retina Specialty Day. The session 2 will start at 11 o'clock. In between, there is 1 hour. This thing is given for Dr. Uday Devgan for his cataract presentations. And we will reassemble at 11 o'clock, and it will go up to 5:30 as Retina Specialty Day, and the whole sessions will, the sequence was given here.
All speakers.
And I thank all the presenters as well as my co-chair and the moderators and all the audience, more importantly, and you made the session very lively. We'll have a, we will
So,
have our own
thank you
photograph,
to
yes,
all the
for a
expert
group.
panel. Can I request all the speakers and the,
Speakers also
the
to come
expert
for a
panel
group
for a
photo.
picture together, please?